Hi there, welcome back to Medical Education in the New Millennium. I'm Dr. Larry Chu.
And I'm Dr. Nikita Joshi. Thanks for joining us.
This is the last class in the series, and we have saved a great talks for the last. Today's subject is speaking up, challenging authority in different medical cultures. And we're really lucky to have two great speakers today. We have Clay Crawford from Stanford's Anatomy Department, as well as Dr. May Pian-Smith from MGH, and she's going to be speaking a little later. But first, I want to introduce our first speaker. Clay Crawford is an anatomy scholar with the Stanford Division of Clinical Anatomy, and he focuses on research and development of cost-effective educational technologies. He is particularly interested in finding ways to improve healthcare training and delivery and to bridge gaps in access to basic surgical care through international collaboration and mobile solutions. Clay is a graduate of the Human Biology program at Stanford. Zoe, do you want to say something as a last word here? I think she wants to say that there's going to be a brief message from Stanford Med X, and then we'll be right back. Okay. Welcome to Medical Education in the New Millennium, a new course from the Stanford University School of Medicine. This interdisciplinary course is produced by Stanford Med X and features talks from thought leaders and innovators from medical education, instructional design, cognitive science, online learning, and emerging technology. Over the course of 11 weeks, we'll consider how to build educational experiences that address the unique learning preferences of today's millennial medical students and residents, address gaps in the current medical education system, and explore what might be accomplished when all healthcare stakeholders are included in the conversation. If you are joining us for the first time, a quick reminder that there's a simultaneous conversation happening on Twitter right now using the hashtag MedX. Christopher Snyder, otherwise known as I Am Spartacus, is the in-class moderator for today's program and will be taking questions from social media. So please make sure to start up your Twitter client to join in the online conversation and interact with today's speakers. Please also make sure to like our Facebook page at www.facebook.com/Stanford Med X. Please note, you are watching a live online program, and there is a delay between real-time events and the live stream you are watching. Tweets from our in-class guests will appear before you see the real-time events they are tweeting about unfold on the video live stream.
Hi, my name is Clay Crawford. As Dr. Chu said, I'm a research assistant with the Division of Clinical Anatomy here at Stanford, and I'd like to tell you a little bit about my experience working overseas and some cross-cultural medical education. So I'd like to begin with a problem. So in an era of shortened training time and a rapidly increasing use of technology in the medical education field, there's a loss of patient contact and human touch. Learning empathy takes a lower priority in the emerging medical education paradigm. There also exists a great need for healthcare in the developing world. Here's a little about me. I'm a third culture kid who was born in New Delhi and grew up in Bangkok and Singapore as the son of international school teachers. I attended Stanford, and when I got here, I was an enthusiastic but naive pre-med. At Stanford, I was fortunate to meet some really great mentors who encouraged me to go outside the bubble. And I'd like to tell you briefly about three of my experiences and how they shaped my view of medicine. So my first year, I traveled to Kathmandu, Nepal, and I volunteered at the Umbrella Foundation Orphanage, experiencing firsthand the perseverance of the human spirit in the face of adversity. I met orphans who carried bricks at the age of 6 and survived beatings, but smiled and still tried hard at school and greeted me with "Namaste, brother," whenever I saw them. I also had the opportunity to experience the wonders of the world, to rapidly mature, and to reflect on my life path. It was a journey of the soul. The next summer, I was fortunate to intern at the Kilimanjaro Christian Medical Center in Moshi, Tanzania, which opened my eyes to the fierce reality of human suffering, the immense burden of global healthcare disease, and the faces and families who make up the statistics. There I had a peak experience, a sudden coalescence of previous training and experience into one clear career path. I declared, this is what I want to do for the rest of my life. The following summer, I spent the summer, had the opportunity to work with Dr. Edgar Rodas and the Cinturandes Mobile Surgery team in Cuenca, Ecuador. With his team, he takes the OR to the patient in the back of a truck, closing the gap in access to safe and efficient surgical care. They taught me that empathy is a powerful, irreplaceable clinical skill that should be learned, and that there's a vast amount of knowledge outside the bubble. Through diligence, responsible and ethical medical decision-making, compassion, teamwork, and commitment, Dr. Rodas' team has an amazingly low rate of complications and excellent patient satisfaction. All team members are equally important, and they work together like a family. I learned the vital importance of the human factor, how social interaction and personal friendship is the foundation of sustainability in medical programs, both local and international. I've been back again and again. I just returned from Palmar on the Ecuadorian Pacific coast, where I was working with the team. Returning regularly can serve as a good refresher as to why we pursue our academic work here in the United States. As one of the surgeons said to me, life is service and service is happiness. I've been so fortunate to have these opportunities, and I'm currently working to help others have the same opportunities. But this is not to say that you need to cross continents or even borders to live and learn from these types of experiences. In our own backyard, there are communities in need. I'm simply saying that taking the leap out of your comfort zone into the wide world can change your experience as a lifelong medical learner, and will make the world healthcare system better by improving medical education in a holistic way. My experiences have solidified my passion for medical service, broadened my perspective, and formed productive, lifelong collaborations. I'm also consistently surprised. My assumptions about skills, resources, facilities, and societies are always off. We are more the same than we are different. Now, before I offer my challenge to you, I'd like to be clear about two things. First, I encourage ethical, responsible clinical care. Know your limits, go where you're invited, and be safe. Second, it's essential to have a two-way exchange of knowledge, both scientific and cultural, which can be achieved through an interchange of people. Be both a guest and a host. So here's my challenge to you. Build safe, ethical, and innovative international interchange programs into the new paradigm of medical education. Thank you. So next up, we have an excellent speaker. Dr. May Pian-Smith is an associate professor of anesthesia at Harvard Medical School. As a Rabkin Fellow and recipient of a Foundations for Anesthesia Education and Research grant, Dr. Pian-Smith developed and implemented innovative curriculum at the Center of Medical Simulation to teach residents the skills and language of speaking up. Specifically, the lessons foster questioning and challenging across hierarchical gradients, with the goal of improving resident education, enhancing the role and responsibility of the residents and care teams, and supporting patient safety. But first, we're going to have a quick message from Stanford Med X.
In 2015, Medicine X will be launching a new program called Medicine X Ed. This special conference, right before Medicine X 2015, will focus on medical education and what might be accomplished when all healthcare stakeholders can engage in a conversation about changing the culture of medicine through educational innovation. Of course, we'll discuss the role technology can play in medical education, but we'll also look at gaps in our current educational system, such as participatory medicine, shared decision-making, patient engagement, cost transparency, patient safety and reducing harm, and cross-cultural competencies. What other gaps might we address at Medicine X Ed? Let us know what you think by tweeting our hashtag MedX. And make sure to sign up online to learn more about Medicine X Ed and how you can get involved.
Clay, I want to thank you for that great introduction. That was such an inspiring story. I'm Mae Pian-Smith, and it is such a wonderful professional and personal pleasure to be here today at Stanford. I have to say that this is my first experience participating in a MOOC, and I'm very thrilled about not only sharing some of my experiences with you tonight, but also learning from you. I look forward to not only learning about the interactive process of the course, but also learning from the ideas that you'll share from this great global interactive learning community. So today we're going to be talking about speaking up across authority gradients, challenging authority in different medical cultures. And so in the next 30 minutes or so, I'm going to invite you to travel with me to explore some themes that have to do with different cultures and different forms of hierarchies. So by cultures, we'll talk a little bit about how patients and caregivers and people who are, for example, from typical Western civilizations may be very different from people from Eastern civilizations, and how that impacts how they think and how they interact with each other. There's also, as many of you know, the hierarchy and the culture within our medical practice. So in the operating room, for example, there's different hierarchy and culture than, say, in the ambulatory care center. So I invite you to kind of travel and think about these different things, and I look forward to learning from your ideas about how your experience in all these different kinds of cultural settings and hierarchical settings impact you and how you struggle with your experiences there. I also maybe want to hold out an umbrella and think about this umbrella of culture of safety, if you will, because I know that we're now participating as learners. We're an international group today. And certainly there are many more cultures and hierarchies than I can even imagine among the learners with this group. And so what I'd like to propose to you today is some themes that may have special relevance to you in the setting of safety culture. I feel very strongly about things that Clay alluded to, that in order for us to be empathic, to have meaningful relationships with our patients and to other citizens, that we feel safe, that we feel we're supported so that we can bring the best to our care of our patients. And this is really how we're going to develop a community of people who do the right thing for the people we care about. So the problem, I'm sure you guys all know. We know that all different kind of hierarchies, whether it's in the medical field or in real life, impact us and silence us when it comes time to speaking up. There is a 2005 study called Silence Kills, where they did a survey and they found out that among healthcare workers of all different types, only 1 out of 10 would dare speak up and report about having seen a colleague do something that might not be safe or might be wrong in the care of their patients. And that's really frightening, that we all belong to this community that lets that happen. So it's a terrible thing for us as caregivers, and it's a terrible thing for us as learners, right? Because we want to feel safe to ask questions and challenge and make things better, and that's how we learn and that's how we innovate. So we decided that we want to, if this is a problem, we want to develop a curriculum or a learning intervention to help people speak up and lower the barriers to speaking up. And so to develop something, of course, we wanted to do a needs assessment. We wanted to figure out how big is this problem and what would the effects be of different cultural hierarchies. So for example, how are American trainees, residents, how are they different from trainees in Japan, for example? And so we did a survey study that was published about 8 years ago. It was a study of trainees. So we had 175 residents from all through the Harvard system. They were internal medicine, surgery, pediatrics, anesthesia, OB/GYN, all different specialties. And we asked them about different hypothetical situations. Would you speak up? Would you not? Why? What influences your willingness to challenge an authority figure? And we also interviewed 65 Japanese trainees. And our hypothesis was that because hierarchies are so much more rigid and because the gradients are so much steeper in Eastern civilizations and cultures, that the expectation and the acceptance of speaking up would be much lower among the Japanese trainees. And so what we did was we identified barriers to speaking up. And what we found is that the barriers to speaking up are very complex, and probably 10 or 20 more studies need to be done to really understand the differences between these different populations. But one thing that emerged is that for Japanese people, whether or not they spoke up and challenged their superior had a lot to do with how they thought they would be accepted socially by their group. It's very important for Japanese to not stand out, but to really blend. And the thing we found about American trainees is that they were often self-censored by fears of retribution and harm that could come to them as people if they spoke up. And so definitely these are themes that we want to explore more, and we feel like these are actually opportunities where we can help improve culture so that these factors don't have such a negative effect on how we interact with each other. However, two big surprises came up. We found that there were very important ways in which Americans and Japanese were very, very similar, and it surprised us. So for example, if the trainees were presented with a situation where real harm might happen to the patient, there was actually no difference in the threshold of the two countries' people to speak up against authority. So if we can kind of shift the worry not about us versus them, but the concern is more focused on some other kind of alternate authority, say the good of the patient, doing the right thing, adhering to a code of conduct, that helps align us a little bit better and helps us to speak up more. And so this is something that I think has been picked up actually a lot in our subsequent research. The other thing that surprised us was that the Japanese and the Americans were not different in their willingness to speak up a second time based on how the first time went. So if they spoke up to a surgeon who was really grumpy, was mean, didn't want to hear from them, they were definitely not going to speak up again if there was another issue. So this sort of points out another great opportunity for us, which is that we need to make sure that we're better about having inclusive leadership. That leaders, whatever their hierarchy is, these leaders need to make sure that they welcome input, that they're grateful for input, and that other people's voice is appreciated and actually can be impactful. So I don't need to say much about simulation to this audience. I know you guys as groupies of medical education are very well informed about simulation. Simulation was a tool that we used to teach our trainees about speaking up because we thought it was nice to create and bring lessons and opportunities for experiential learning to our learners rather than waiting for chance during the course of a day. And so to make our learning intervention really impactful and really meaningful, we wanted to base it on adult learning theory. And so many of you here are very familiar with the research and teachings of David Kolb, who is a professor of organizational behavior at Case Western University. And he's published decades of work on experiential learning. And he's the one who developed this kind of famous way of thinking about different learners and different learners' needs. So here on the, I don't know if this shows up on the screen, but on the y-axis is it describes the continuum, the spectrum of ways in which people like to get new data, new input. So on the top, there are a lot of people who need to experience things to really start to learn new material. On the bottom, there are people who need to conceptualize or to think about it very theoretically. So those would, for example, be people who like didactic lectures, for example. And you can imagine that yourself, you're somewhere on this continuum. And then on the x-axis, thanks, is the process continuum. So once you have the raw information in your brain, how do you package it and how do you make it stick in your mind so that it can be retrieved later when it's useful? And so on one end of the spectrum, there are people who need to reflect, they need to think about things conceptually, they need to watch, they need to talk about it. There are people who need to experiment, they need to get their hands on it again, they need to try it out, test it out, and so forth. And again, I'm sure each of you can imagine that you're somewhere along this spectrum. So according to David Kolb then, depending on where each learner is on each of these axes, you land in one of these 4 quadrants. And so for learning to be effective, you need to know where your learners are at and address your intervention to that. So with so many different types of learners, it's not surprising then that it's hard to develop a single curriculum that's going to be meaningful to everybody and is going to be useful to everybody. And so what David Kolb suggests is that you kind of run around the bases of the baseball game almost and touch all the bases so that somehow you connect with each of the learners in the way that they need to be connected with. And so we used this idea when we developed our special curriculum for teaching people how to speak up across authority gradients. And so I'll just sort of run with you around the baseball bases for a second. You can see what we're talking about. So on the top here is experience. So what we did was we recruited 40 anesthesia residents at my institution. I said, come to the simulator. We're going to practice some OB operating room emergencies. And also we're going to work on some team training and some communication skills. And so they were happy to learn and they joined in. And they came and they managed all sorts of obstetric emergencies like placenta previas and abruptions and emergency C-sections and all sorts of things. But what they didn't realize is that partway through these scenarios, scripted actors playing the roles of attending senior anesthesiologists, attending senior surgeons, or very scary looking circulating nurses would start to misbehave. Then according to their scripts, they would start to give directives to the trainees that might not be in the best interest of the patient. And as you can imagine, the trainees felt kind of uncomfortable with this. Some of them went along, some of them didn't, but it was very challenging for them, as you can imagine. So then they were very happy to be taken out of the simulation into the debriefing room where we had an opportunity for reflection. They could kind of shed all the feelings that they were having at the moment, shake it off a little bit, reflect a little bit, review some videos of what had just happened, talk about it. That was sort of the reactions phase. And then we went around the bases to this conceptualization phase where we wanted to, if you will, load their toolbox, give them some tips and techniques that would help them to approach this kind of challenge in the future. And so let me tell you a little bit about what happened in the conceptualization part of the debriefing. So basically what we did is we taught them some techniques that are well described in other domains, not so much in the medical field, but in other domains. Many of you know that simulation has its roots derived from the aviation industry, cockpit resource management. And many of you may know that there's actually protocolized methods for people to speak up in the cockpit. So for example, so imagine that the co-pilot, who is of lower status than the pilot, is a little bit not comfortable with something that the pilot's doing. It's actually not only his right, but it's his responsibility to speak up and challenge about that. And so they have actual protocols to do that, and they call this the 2-challenge rule, where if he speaks up about his concern and he doesn't get a good answer, he's actually required to speak up again and challenge again. And if it's really unsuccessful, and if he's really concerned about the safety of him or his passengers, then he's actually authorized to take over controls. Okay, so that's something that they've put in their protocols. It's supposed to be, it lowers the threshold of that happening. So we tried to introduce the idea of, gee, could you make this happen at the bedside with the patients too, when you're concerned about the patient safety? We can't really if we're having a discussion about how to manage the patient, I don't think we could jump in and like do the operation ourselves necessarily, but maybe there are other techniques that can be employed. The other thing we taught them was this technique called advocacy inquiry, and that gets its roots from organizational behavior. There's about 3 decades of research about how to use language that invites people to be part of the conversation, but doesn't make them feel defensive. So you're going to say very explicitly what you see. So you advocacy, what you see, what you observe, what you're concerned about, and inquiry, you want to invite the other person to share their perspective. So let's talk about these 2 people in the cockpit. You can imagine the co-pilot saying, gee, advocacy inquiry, it looks like we're getting very close to that mountain, and I wonder what your plans are. Let's say nothing comes back at him. So he should ratchet up his concern. He should do the second challenge. He should punctuate his question with his concern. So, you know, I see we're getting closer to the mountain. I'm concerned that we may actually have a collision, and I wonder what your plans are, something like that. It feels a little bit awkward, but that's sort of the concept. And it's really important, actually more important than the words itself, is that you have this conversation with a stance of true, authentic curiosity. So you cannot go into these conversations thinking, that person is really a stupid jerk, but I'm going to do advocacy and inquiry. It's more like, I need to put on my detective hat because this is a bright, well-intentioned person, but the actions don't seem to jive, and I'm really curious and I'm wondering about this. You know, people who do statistics. So we know that things are real when they're within 95% confidence limits. But also that tells us that maybe 5% of the times real things are not as they appear. And so, for example, could he start advocacy inquiry with the pilot and find out that the pilot, who's actually quite experienced and quite bright, says, oh, I happen to know there's enemy fighters right around the mountain, and I figured that if I come very, very close to the mountain, we will be shielded by their radar, and we will get away without their attacking us. So we don't know that brilliant thing unless we were curious and we asked and we started the conversation. So that's the idea of being curious, okay? And I think that whenever you're talking about the cockpit, bedside in the operating room, people who are from different cultures, maybe from different parts of the world, who have different concepts and different frames of perspective, it's this curiosity that's going to help us connect to overcome these barriers and to do the right thing. And if unsuccessful, we say, don't take over controls of the plane, but call for help. Okay. So that's what goes on during the debriefing, and then we come to experimentation. Once they learn that, they go in, they get to try another scenario where things zig and zag and people misbehave and they get a chance to speak up. In a little while, I will show you some data comparing the language that they use here after they get the lessons in language versus how their language was initially, okay? And then as we run around the bases, eventually we don't want them to just be good at simulation. We want them to come all the way around. We want them to be great taking care of real patients in the future, right? So what we're going to do in a minute, not quite yet, but I'm going to play a video of somebody who participated in this experiment, if you will. It's an exercise and an experiment. So I'll set it up for you. This is the anesthesia resident here on the right. By the way, he gave permission for me to share this video with you. And as we enter this scenario, he's already taken amazing, great care of this simulated patient. So she's had cardiac arrhythmia, she's had tons of bleeding, all sorts of things that happened to her, and he's managed it great. And now as I start to close, the surgeon, who is an actor, says something about, wow, this patient has so many adhesions, scar tissue. Actually, this patient would be great for this research study I'm doing. I'm looking at the effect of either a steroid versus saline given IV to see if it affects formation of scar tissue in the future. It could be a really good thing for this patient. I think she should be in the study. Why don't you give the drug, study drug, and we'll call it a day. And the only problem is that the patient is under general anesthesia and no informed consent has been obtained. So you can understand that's something that the resident would not feel comfortable being a part of, okay? So now we'll play the video for you.
Or to 100 milligrams of solumedrol, and I think she would be a great patient for the study.
Yeah, she's got more adhesions than that last study patient.
Yeah. So, Robert,
Yeah.
can you go, my attaché is right there,
Yeah.
and there's a little box with the study drug in it.
Oh, yeah, yeah. I see.
So it's like the next number on there, which I think is either 14 or 15.
Oh, just a minor question.
Yeah.
Did she sign the consent form for a drug
She
study?
didn't, but because I didn't know she was going to have so many adhesions, but she's been my patient forever, so I'm sure she'll sign it afterwards.
And number
it's nothing
15.
that's going to hurt her. In any case, the solumedrol may.
So you haven't talked to her about this at all?
I haven't, but I'm sure it'll be okay. I've known her since
Yeah.
she was a teenager. And if it's
I-
saline, it's not going to do any good, any harm. And if it's solumedrol, I mean, years ago when we had nothing else to give, we used to give patients Phenergan and dexamethasone. So
Yeah.
I'm sure it'll be
Yeah.
fine. So, but the protocol of the study is to give it before she's closed, and I'm just about ready to close. So if you can just go ahead and push it, then we can get out of here.
There we are.
Unfortunately, I think I do have a problem with that.
Why?
Yeah, well, since patient hasn't signed any consent form, is not notified, can constitute a violation of IRB as well as.
Well, but you let me worry about that. I've known her forever, and I think that it really may help her. And so I
Yeah.
really like her on the study. And
Yeah.
I've known her since she was 16. I've just done
Yeah.
her first pelvic and seen her through her married life.
Oh,
so
you did her first
I did
pelvic?
her first pelvic. First pelvic, first baby. So, so why don't you just go ahead and give it?
Well, I cannot give it because I do think that's probably an
I'm sorry?
important issue needs to be worked out before all this happens.
Okay, thank you very much.
So that scenario was only a minute and a half, 2 minutes, but it was painfully long, I know. And I was looking around the room and I saw how uncomfortable all of you were because that's just such a horrible, difficult conversation. And hooray for this resident for whom English wasn't even a first language, for absolutely digging his heels in. So good for him. But we also wanted to help him and help others be diplomatic, not only do the right thing, but feel like they're a contributing part of the team to just sort of move the whole team forward in a collaborative way rather than just being stand your ground, not doing it, okay? So I'm just going to bring you forward. So this is some of the data. So what we did was we analyzed the language and we rated the language on a score of 1 to 5. 1 is where they didn't say anything. 5 is where they did crisp advocacy inquiry. I know you want me to give the study drug. I really don't feel comfortable doing it because the patient does not have informed consent. Boom, 5, okay? So given that, then we looked at their language before they learned the techniques and after they learned the techniques, whether they were challenging attending faculty anesthesiologists, surgeons, or circulating nurses. And what I'll just tell you is that for each of the physicians they were challenging, the language got better. So for anesthesiologists and surgeons, and these were statistically significant improvements. Interestingly, for the nurse, their language did not get better challenging the nurse. And that was really surprising to us. Why is the resident having trouble challenging the nurse? And that was actually a cultural thing that we learned about, which was so enlightening. When we asked them about it, a couple of answers came out. One was, oh, it doesn't really matter what the nurse is doing. I'm not really listening to the nurse. And the other thing that came out was, I'm not really going to challenge the nurse because I don't really need the nurse's help. It's okay. So what we realized is, wow, that's horrible, that the trainees are missing an opportunity and don't realize how important the nurses are as a member of the care team. And so that became an area of focus for us and intervention for us as well. So this was a purely cultural thing. So not East-West culture, but hierarchy culture in the operating room. It was really fascinating for us. Okay, so when we teach, we want to make sure that the lessons are learned, they're retained, they're transferable to future situations. as I said, we're not just trying to make people good at simulation. We want them to be good taking care of patients. We want them to remember what we're talking about. So we did this follow-up study where we tracked down these residents 2 years later, and we invited them to be a part of a new experiment exercise. So all these people were followed up. I tracked them down by email. I invited them to meet me online. And what they did was when they came to this website, they saw 4 out of 5 trigger videos. And the trigger videos were of an anesthesia attending, me, talking to them in the operating room and asking them to do something that was maybe a little bit questionable and giving them an opportunity to challenge me. And so what would happen is that they'd see the trigger video, then the screen would go black, and then they would talk to me over the computer directly. So we'd have a spontaneous conversation and we would get their language in the moment. It wasn't filling out a questionnaire. It wasn't saying what they thought they needed. They were responding spontaneously. So I will show you what that looked like. And this is a 1.5 minute video. So just so you know how easy and inexpensive these technologies can be to make, a high school student helped me film this. He edited it and he put the jazzy music to it, which kind of amused me, like what high school students think happen in the operating rooms. But anyway.
Oh, hey, listen, great. I'm glad you're back. I hope you had a good lunch. So while you were gone, let me tell you what happened. I brought that other patient to recovery. She's fine. And then we had to come rushing back with this new patient. Thank God the spinal went in right away and everything's okay now. Everything okay? Yeah. Yeah, okay. So listen, I need your help. I gave that last patient 3 milligrams of Doromorph. Can you just go to recovery and initial on the chart that you witnessed that I wasted the rest of it?
Okay, so I don't know if each of you understands what happened, but basically I'm asking the participant, the learner, to witness the disposal of narcotics that they didn't actually see, sort of as a favor to me. I'll just initial that you saw me take care of it. So as you can imagine, that's not something they should do. So let me just show you how their responses. So remember, we don't want them to go along with it. We want them to do the right thing that's ethical, but we want them to be a team member. We want them to be collaborative. And so let's listen to the different answers. Okay, so first we'll listen to the first guy. If you could just initial that you wasted it, that'd be awesome. Thanks.
Okay.
So you know where the recovery room is?
I do, thank you.
Okay, great. Thanks. So in each of these instances, I was thinking about the 2 challenge rule. And no matter what they said, I would say something back so that they would have a second chance to challenge or whatever. In this case, second chance to agree. Okay, so the next one. So help me out here and just go sign as a witness, okay?
I'm sorry, I can't do that.
But we do it all the time, right?
Yeah, but that's not right. You could find somebody else to do it. I can't do that.
Oh, all right, I guess you're right. So she's not going to compromise herself, but she's not particularly helpful either. Now this third one I want to tell you, you have to listen carefully. She's very uncomfortable. She's struggling with the language. But if you listen for it, you will hear the advocacy inquiry. Just, if you don't mind, just going, to the room and witnessing that waste for me, that'd be great.
So I totally hear you, May, that you didn't have anyone around when you wasted, but I'm uncomfortable with signing that I saw something I didn't actually see. What do you think we maybe could write to make everyone feel more comfortable?
Well, we do this all the time, right?
certainly there definitely people will sign things when they didn't see it. But I'm really not feeling comfortable in this situation. Maybe one possibility is you could write down that you had thrown it out by mistake before anyone was there, and just write down what happened. I'm happy to sign that.
Okay, I appreciate that. That sounds like a good solution.
So good for her. She did what she thought was ethical. She helped me figure out the right thing to
All right,
do.
thank you.
We could move it forward. We could do the right thing, and I didn't have to feel defensive about it, right? So I think that was a really good thing. Okay, so we're gonna wrap up soon. What I'm gonna do is show you how people did with that follow-up study. So now we want to know, if we teach people how to speak up, can they do it 2 years later? So let me first just tell you that of the original 40 people who participated in the study, I could only reach 15 people by email. But all 15 people 2 years later said, absolutely, count me in. I'm going to meet you online. We'll do this thing. So first I went back to see how did they do 2 years ago speaking up in the simulation room. And we found that, yes, their language improved pre and post debriefing 2 years ago. And when we caught them again 2 years later, their language score on a scale of 1 to 5 was somewhere in the middle. Okay, so maybe they forgot a little bit, but they were better than their baseline. Then we realized, you know what, we have to have a control group, because these people, 2 years have gone by, they have more experience, they have more clinical experience, they're more established. Maybe time can affect how they speak up. So what we did was we found a control group, 45 other people, trainees, either senior trainees or young faculty from around the country. We specifically picked them as control groups because they were familiar with simulation, they were familiar with role play, they felt comfortable doing this kind of stuff, but they hadn't actually had this speaking up intervention 2 years earlier. So they were our control group. Then we realized, remember the 5-point scale the perfect 5 was given for people who gave crisp advocacy inquiry. And for our control group, it seemed unfair to expect them to have crisp advocacy inquiry if they didn't learn about it. So instead, we recalibrated all the scores, and we took our original 15 people and we switched them to a 4-point scale, where anyone who'd gotten a 4 or 5 before was given a 4. You can see that's their score on a 4-point scale, and we compared them to our control group, and we saw that actually their language, even 2 years after the learning, was better than the control group. So on the one hand, we can say, hooray, we did something, we thought about David Kolb, we did this great thing in the simulation center. Even 2 years later, people still remember how to speak up. Isn't that great? But on the other hand, look at the numbers. They're all 2s. Like, even knowing that the whole idea is to speak up, people cannot speak up well. Why aren't they all 5s? And so we realized that speaking up is hard to do. Even when you have the tools, even when you know it's the right thing to do for you or your team member, for the patient, it's just so hard to do. Now, part of it has to do with being heard, right? So we can speak up, but unless people hear us, we won't know that our speaking up actually is impactful and makes a difference. So in our own world, we have been teaching senior faculty people, this is what we're teaching residents, you better listen for it. You know, and you hear somebody speak up, you need to respond to it. Even senior faculty are learning about speaking up because we find that they have their own hierarchical issues. Anesthesiologists, surgeons, nurses, they all have their own complicated interactions that can affect this kind of communication as well. And then I want to refer you to this great book called Teaming, written by Amy Edmondson, who's a Novartis professor of management at Harvard Business School. She wrote this fantastic book, Teaming, How Organizations Learn, Innovate, and Compete in the Knowledge Economy. I don't get any royalties from this, but I think it's a great book. And she talks about hierarchies and communication in the business world and how it may relate to what we deal with in the medical world. And one thing that she talks about is self-censorship. So we censor ourselves because we have what she calls implicit assumptions. We think that people are not going to take us the right way, that the harm to us, the risk is too great to speak up for any potential benefit, and so we shut ourselves up. So we need to work on, as an organization, how to overcome those barriers. So what she says is overcome fears of personal risk by sharing a common greater goal. So we're taking care of the patient. It's not about me embarrassing myself or me worrying about the grade I'm going to get or whatever. That teaming is a verb. Let's focus not so much on the product that we're making, but how we come together and how we integrate our efforts to do it. I'm told that that's why Navy SEALs are so amazing, because they can quickly team. They figure out who's doing what, and that process is like clockwork. Interdependence we need to sort of work together, cross-monitor each other, affect each other's movements, and that's how we assure quality in settings that are kind of gray, ambiguous, and uncertain. And this applies to the business world, to the hospital, healthcare. Learning fosters innovation and resilience, and there have been many studies that show that as healthcare workers, burnout is a horrible detractor. It keeps us from not taking good care of ourselves and our patients and not interacting well with each other. So the more we can improve communication, improve the culture of safety and our own resilience, the better off everything is for everyone. So as in closing then, I want each of you, because everyone here comes from their own culture and you're dealing with your own sets of barriers and the hierarchies that you deal with, think about how the tools, language, and techniques that we've talked about might help you, might help lower the field for you, and how in your world, how you can make it stick. So how can you overcome these worries that we all carry around with us that make us afraid to speak up? How can you normalize speaking up? Sometimes I recommend to residents and students that they hear their own voice by speaking up in low-stakes situations to other people. Just get your voice in the conversation when it doesn't really matter. Sharing mental models, thinking out loud, having transparency so people can know where you're coming at, what you're thinking about, help you recalibrate if you're off mark, and you can also defibrillate other people's fixations too, sometimes if they're on the wrong track. Frequent inoculations, the more we do it, the easier it is. And where can you be an inclusive leader so that you can create this kind of culture change? And how can you encourage your leaders to foster this kind of change? So really we want to go from this problem to something maybe like this, or better yet, something like that. And as we leave that, I want to challenge to you also. Clay started this, I'll do that too. I would love for you to actually apply something that we talked about today. Try advocacy inquiry. Try thinking out loud. Try being transparent to your colleagues. Try to ask questions. Try to be curious to overcome these barriers that we face in so many facets of our lives. Email me. This is my email. Email me and tell me your story. And 1 month from today, I will draw one entry from all these emails that I get, and we'll give an iTunes gift card to that person. But really, the idea is to think about what we talked about tonight and see how you can apply it tomorrow to the people around you. Thank you. Thanks, Clay.
That was an excellent talk. So I think we're going to take some questions from the audience. If any of you have a question, please raise your hand.
Thank you for such a wonderful talk. Thank you so much. That was so interesting. I think my question to you is, how can we apply this for an interdisciplinary team when it comes to healthcare? Like I was saying a little bit before, I came from the tech world where it's much more flat in terms of hierarchy to healthcare, and I'm a nurse, and my experience has been interesting watching my colleagues from a cultural perspective. There are some who, because of the way nurses grew up or practiced nursing outside of US, they're much more submissive and would follow the orders or the recommendations that are given. And in that case, they can risk the patient's health, and then the liability is on the nurse, even if the order was incorrect, because she's required to question it. On the flip side, as a nurse, you don't have the same authority that an MD does, and you kind of pushed out of the equation or treated lower. So if you speak up, to some extent, you also face that resistance. So how do you find that happy balance, and how do you change the culture of healthcare where every member of the team is respected and participates?
All right, thank you for that great question. So first of all, I have to say I'm still looking for that perfect balance point. I think it's a very challenging situation. But I will tell you that there are two very explicit things that I'm doing almost every day in my practice. One is that we have, both related to nursing, we focus on, again, the team and how the team comes together, and not about individuals. So it's not about what each person, what their status is or what they bring, but how do we function together. And so every week I participate in interdisciplinary or interprofessional simulations where surgeons, anesthesiologists, nurses, and surgical technologists work together to manage intraoperative crises. And we, for example, have it so that each person has some kind of secret information that, and the effective care of the patient requires that everybody share their information. So everybody is important and contributes to the care of that patient. Another thing we talk about is in debriefing. So the nice thing, it's not often enough during the course of our real days that we actually can debrief and reflect on what happens, or to give feedback effectively to other people. So in those simulations, people are purposely asked about how the communication went, and we hear from each other that people notice things that perhaps they didn't share. So I would actually say to a nurse, during this resuscitation, the surgeon was doing CPR, but he only was pushing once every 60 times a minute rather than 100. We all saw that. How come you didn't say anything? And then we'll have a really wonderful conversation about that. So everybody has a voice. We want to normalize and appreciate the contribution that everybody gives. The other thing we do is I work on the labor floor, and every day at 4 o'clock we have debriefing rounds, communication rounds sometimes we'll call it, where everybody who is available comes. Most of them are nurses, some midwives, some obstetricians and anesthesiologists. And we just talk about good or bad communication things that happened during the day. You sent that patient over from the emergency room and you didn't tell us the patient was coming, and we weren't really prepared. And so next time we'll take better care of the patient if we are on the same page about it. Or, thank you, you told me that you'd given that drug, and that made sense to me, and so I knew how to resuscitate the patient. If you hadn't shared that with me, I wouldn't have been as effective. Thank you. That kind of stuff. So we try to model it every day, and when we do that, and we do it very mindfully like that, we all see and we can appreciate the contribution that everybody makes.
Hi, thank you so much for your talk. One question that I had, so when you talked about speaking up, one thing that came to mind was just how it's so ingrained within us from even an early age about how we need to be respectful of our authority figures. And even in the classroom setting, let's say a professor makes a mistake and a student calls out the mistake, you can just hear people saying, oh, so-and-so thinks they're know-it-all and just shouldn't have spoken up even if it helps the whole class get to the right answer. And so I think in the example you gave where the resident spoke up, I think a lot of times residents might not necessarily be afraid of what the authority figure might say to them, but what everyone else around them is thinking of them. So what kinds of things can we do to help sort of the peer-to-peer interaction and how our peers perceive us?
Yeah, thank you. I mean, that's exactly the issue that came up when we surveyed Japanese people. They didn't want to stick out that way, and they were worried about what their peers would say. So I think that the important thing is to not confuse challenging or speaking up with disrespect, right? Because if we respect someone and we care about them, we want to help them to do the right thing. So if we see them clearly making a mistake or saying the wrong thing, we want to help them, right? And so if we speak up properly, we're actually doing them a favor. The other thing is to think about what we talked about in terms of curiosity and thinking about the greater good, what your motivation is for speaking up. So if it's just, not that you would do this, but certainly we all know people who would speak up just so they can show what they know. So that they give themselves away when they do that. But if we're curious because the book said this, and this Nobel Prize winner lecturer is telling us something that sounds a little bit different, and I don't really understand, and I just need a little clarification, then when it comes from curiosity like that, everybody is so happy that you asked, right? Because everybody benefits from that kind of more meaningful and more authentic kind of conversation.
I had a slightly different question from an educator point of view. You really beautifully described your research, and it was fascinating. Did you ever have to deal with a student or a resident who inadvertently went along and did something that they later on regretted? And if so, how did you deal with that during your debrief? And was there ever any sort of a emotional breakdown or something that you had to deal with as a consequence?
Yeah, so actually the whole reason I got into this area of research is because we were doing simulations, and an actor by accident said the wrong thing to the resident. Oh, give such and such a drug. Actually, it was the wrong drug, and the resident went and gave it. And we thought, whoa, how did that happen? And it made us realize that this kind of stuff happens in simulations and happens in real life, that people do what they're told. And it hurts not only patient safety, but their own learning when they don't stop and ask about it. So that actually, having seen it happen, that's what made me try to explore this. So yes, absolutely, learners are vulnerable, right? And so, as you can tell, my flavor of the whole thing is to be very upfront about stuff and to be very explicit about what I'm seeing and what I'm thinking. But I frame it all with what we at the Center for Medical Simulation called the basic assumption. That everyone here is bright, they're well trained, they want to do the right thing, and they want to learn. And you know what, just like in real life, things zig and zag, you make mistakes, things happen. And we should be curious about that. How did that happen? That somebody who is so brilliant gave the wrong drug? I'm so curious about that. And so if we can all feel safe about looking at our mistakes that way, then we have a chance of learning from them.
I want to echo Dr. Joshi and say thank you for the presentation of your research. It was really compelling. I had a question about maybe ecological validity within it. So within the experiments, were there any negative cases where there actually wasn't a problem that occurred? Or were there even ambiguous cases where it wasn't necessarily something clearly wrong happening, but something that might actually really need that inquiry advocacy framework to help the resident understand better what was happening?
Yeah, so thank you. I didn't really go into the details. So I actually tried to purposely create situations that were gray zone, that were not absolutely stupid, ridiculous. But the idea was that whether it was right or wrong, it deserved a conversation, right? It's not exactly what's in the textbooks. I'm curious about that. What's your take on that? So we purposely created that. And actually in the video, trigger videos at the end, we had some potential conflicts that were so vague that people either didn't pick up on it or they noticed little things in the video and they thought that was what they were supposed to challenge about. So that, again, whenever anything unexpected happens, I get all excited about it because I want to go look at it and try to understand that better. So yeah, we had a lot of those kinds of situations.
I'm just going to wrap things up for a little bit with a few shout outs. So a shout out to A.M. Cunningham and M.L. Dunham, Adan Abdur, and EDS Patient Solve for joining our conversation tonight. I'm going to end with one question from Twitter, and this is from M.L. Dunham. What are the biggest ecosystem challenges beyond training to questioning authority? So, what can we think of beyond training, maybe in terms of transforming a culture, perhaps, to challenging authority. I'll let him have. I'll let Twitter have the last question tonight.
Okay, so absolutely. I think that what I tried to sort of, well, what I kind of inadvertently showed you with my research was that it's not about the training, really. It's about the culture. So we can learn this stuff, we can practice, but really the social barriers and the cultural barriers are huge. And so we need culture change, we need institution change, we need leaders who are courageous and who are going to stick to their guns and support people to speak up. We need people who are going to get rid of disruptive authority figures who are not helping the organization and not allowing us to bring our best to our work and our care. So those are definitely, that is where it is at. So thank you for asking about it.
Well, Clay and May, thank you so much for your really inspirational talks tonight. I think you've both threw out challenges for us. We're really, I think, energized to end this class, to go out there and do some great things. So thank you so much for being in our class. Out there, thank you so much for joining us. And we'll see you soon. We'll see you at Medicine X. We have Medicine X Ed, which is our education conference focused on looking at the future of medical education. And that's a new conference Medicine X is doing this fall, September 23rd and 24th, right here at Stanford. So actually, we'll see you then. Bye-bye. If you like what you see in this class, be sure to check out our online course, Engage and Empower Me, a new online class from the Stanford University School of Medicine. We are featuring presentations from patients and experts on participatory medicine. Through this course, we hope to empower you to take part in creating a more inclusive and collaborative healthcare system. The course can be found at class.stanford.edu. As a reminder, this program is made possible by support from the Stanford University School of Medicine, Department of Anesthesia, Stanford AIM Lab, Stanford Hospital and Clinics, and the Agency for Healthcare Research Quality. If you haven't yet done so, please take a moment to like our Facebook page at www.facebook.com/Stanford Med X so you can continue the conversation online and stay informed of program updates. On behalf of Stanford Medicine X, the Stanford AIM Lab, class faculty, myself, Dr. Larry Chu, Dr. Kyle Harrison, and Dr. Nikita Joshi, thanks so much for joining us for this course. We hope you have been impacted by the stories we have shared with you and the information that you have learned. Stanford Medicine X believes that healthcare innovation needs to include all stakeholders, including yourself, our viewing audience online and on Twitter. Your questions and engagement with us this quarter have added a vibrant voice to our class that is an important component to our success. Please continue to stay informed, educated, engaged, and empowered through the Medicine X community. Thanks so much for being part of our course.